Ah, hmm,
Happy Friday
okay, good
morning.
morning. Should we let some folks?
Yep.
What do you
Yeah.
think?
Let's let people get in here and then we can get started.
Okie dokie. Turn off this Ismo. Hmm.
Okay. I think we can just at least get into the intro part.
Okay. Well, hello everybody. Welcome back or welcome here the first time. We love these webinars. Just a little reminder or new info for folks. This is basically a safe place to think and feel and ask questions of pretty much any old stripe. We'll get to that. The way we usually start is, and I'll introduce my friend Kate here in a moment, but Kate and I will run through some slides to kind of level set around this subject. They will not be comprehensive. They won't touch on everything, but it's sort of an overview so we get in the ballpark together. And then the fun part, which is the discussion and Q&A together. So with that, let me cut you over to Sonia real quick, and then we'll bring Kate in. Hold on. There we go. Sones, any guidance for the crowd?
Yes. Good morning, everyone. Thank you for being here with us on a Friday, especially a holiday Friday. We really appreciate it. So Kate and BJ are going to go through some slides that cover POLST and DNR. And after that, we hope to take your questions. So you can do that in two ways. You can click the raise hand button and you can ask your question aloud to Kate and BJ. Or if you would prefer not to do that, you can type it into the Q&A area and I will read it aloud for you. So two ways to go. Raise your hand or type it in. And either way, we're looking forward to addressing your questions so we can help clarify everything around these two forms. Thanks again for being with us.
Thanks, Sones. And yeah, guys, on that note, I think we kind of said as much, but really, this is a big old subject. It's kind of confusing, like a lot of things in and around healthcare and serious illness. And so please, any questions go. Basic boundaries here are simply just respect for yourself and others, and that's about it. So otherwise, anything goes. Please use this time. So, okay, with that, so I want to introduce Kate. Some of you guys may remember Kate. I think it was about a year ago that we did a version of this. So Kate Cataldo is a hospice nurse and death doula who lives in Los Angeles and has kindly put up her hand to help us or replied to our requests, our pleas to help us with this subject that it's so important. And it's also can be so confusing as hell. And thanks to good old paperwork, it can be boring as hell. But it is the subject underneath these forms is anything but boring, and it's extremely consequential. So, with that, Kate, welcome back. Thanks for joining us.
Thank you for having me. Thank you for the intro, and thank you for having me back. I'm so glad to be joining you all.
Great. Okay, well, let me hop ahead here and let's jump in. Lots to talk about. So POLST, maybe some of you guys will have heard of this. It's an acronym. And each state now, I believe, Kate, all states have laws in the books around POLST and MOLST and all the different acronyms. Do you happen to know?
I didn't say for sure, but they've been around for long enough that I would think so. They just might appear a little different. Like in New York, we called this a MOLST, but so there might just be different names. But I think that most states do, if not all.
I think that's right. And it's an important advance for a couple of reasons that we'll discuss. But just to ground us, what the heck is this tool? So POLST, the most common, or at least in California, the most common acronym for this form is POLST, Physician's Orders for Life-Sustaining Treatment. MOLST being medical orders for life-sustaining treatment, et cetera. So they're all the same content. Each state, pretty sure, has one, and laws on the books that make these legally binding. And that's a huge distinction here. But otherwise, Kate, what's the difference between a POLST form and, say, an advanced directive or a living will?
That's a good question to start with. I think that it's really important distinction between the two, because a living will is somewhere where you write your wishes. about future treatments you may or may not want. And the POLST or the MOLST is where a physician actually signs into order those things. So there are things that have to be followed. And I think this is really important when it comes to talking about DNR specifically, because I've seen so many cases where people write in their living will, like if such and such happens, I want a DNR. And they're like, I already wrote it down. I already had the conversation. I already put this into play. But these orders are really important if and when that time comes that, you know, someone's heart stops. Medical providers have to intervene if this paperwork isn't in place. They can't just go by stated wishes on a living will. So I'd say that's maybe the biggest difference between the two.
Yeah, and I think that's probably why these forms came into being. Advanced directives, aka living wills, have been around for a long time, but they are not. They're not medical documents. They're legal documents, and did not have legal standing because they were not signed by a physician. In other words, any medical treatment in our healthcare system has to be, you know, ordered by a physician. And so an advanced directive that may be beautifully state all your wishes may not have enough teeth to it. And in a busy ER, or perhaps in a family where there's misgivings or different ideas of what should happen, it's a little too easy to put an advanced directive on the shelf or throw it away. It's much harder to see a POLST and ignore it because that doctor's order. And that there's legal standing for these forms in exactly this way. So most of us end up with both an advanced directive, a longer document, as well as a POLST. So to sort of protect you to the hilt. I mean, let me say one more thing here, guys. Let me sort of contextualize this too. I'm sorry, I kind of presume that we're all starting from the same point here. But these forms, why are we talking about these forms in the first place? You know, so thinking about your own care, either when you're living with serious or chronic illness yourself now, or for down the road. I mean, that's the advanced care planning, is thinking through when, to use your good catch there, Kate, not if, but when we find ourselves in trouble or on death's door. There are different ways that the medical system can go. And the medical system has defaults in it. So if you don't say what's important to you, it will almost always default to more invasive care, more intensive care, more care, and presume that everyone just wants to have a pulse, period. So when in doubt, you will have full code. They will take you to ICUs, all sorts of gear and life support to keep you alive. So that's often a perfectly good response, but often too, it's not the response you want. Or that intensive invasive care is not likely to help you or serve your goals. And so because of all this, we need to find a way to state our wishes as individuals so people respect our wishes. We have to find a way to state our wishes in advance before it's actually an issue. Because when you're in the ER and in extremis and your heart's stopping, that's not a time to be making big decisions. So anyway, that's the sort of context why these forms are very important. And all of us should have an advanced directive, really. When you turn 18, there should be a rite of passage because you're legally an adult. Most everyone will agree advanced directives are very important, but very few people have actually completed them. You know, so that's a force for us to recognize here. And then I would also say, I don't know, Kate, please jump in. I hear myself talking a lot, but when to think of a pulse. So if you got an advanced directive, when do we want people to think of taking the next step and getting a POLST?
Yeah, you read my mind. This is actually what I was kind of thinking about while you were speaking. And I think it's like I personally have a living will I have an advanced directive. Those are my stated wishes, but I don't have any orders in place. And so we see these forms kind of come into play often. They really could at any time. I could call my doctor up and say I wanted a POLST filled out, and they maybe would have some questions. But really, the reason why I don't have that yet is because if something happened to me today, the defaults of the medical system are okay. And you can list these in a POLST. Like I could say, I want CPR and I would want all the measures. But I know that if something happened to me today, that would already kind of That's how it would play out. And that's why I don't have any medical orders in place. I have my living will, but it's equally as important. I have my living will because if something happens to me and I can't speak for myself, people will know how to have a conversation then about this POLST document with my physician. So the wishes are important, but I think that the POLST usually, in my experience, comes in when there's more serious illness and we're kind of having conversations about, like, we're always having the conversations, right? But like when there are scenarios that we start to think about maybe these treatments, some of these things aren't something I would want, or I wouldn't want my life sustained in this way. When it becomes like, I'm not saying it very clearly.
Well, I'm with you, Kate. No, it's just such tricky water. Sorry to interrupt you.
Oh, that's good.
I was just going to say, so I think what we're saying here is if one of the sort of see if we can boil the message down for everyone's sake, including ours. It's like everyone should have an advance directive. And we should all be thinking about our mortality and what happens when we can't speak for ourselves to protect our wishes and our loved ones from agonizing over what would we want. That's a way to suffer unnecessarily. If we state our wishes, then people who love us know what to do, and it's a kindness to them and to ourselves. So we should all have advance directives, please. And I think it sounds like I think I agree with you. A POLST becomes really important on top of an advance directive when you start having wishes besides the defaults of the healthcare system. When you start thinking of moments where death might be preferable to this or that life support, or when you're really ready to make comfort your primary goal. And that's oftentimes in the setting with people who are living already with chronic or serious illness, for whom a spontaneous trip to the ER or a call to the paramedics is a little more likely than for those of us earlier in life walking around without illness. So if you're sick in any way chronically, if you really just want to be super careful and bulletproof your wishes, that's when to think of a POLST. And when to think of an advance directive, always. Does that sound right?
Yeah. Yes, I agree. Thank you.
All right, thank you. Yeah, this is teamwork. Because again, this stuff is kind of simple and in so many ways not. So anyway, we'll keep moving here. So, okay, what's this? So as you pointed out, the code status, and we'll get to that in a moment, is part of the POLST. But so what is this what is the DNR form? When should we think of this thing?
So a DNR form, a POLST and a DNR form, if your wishes are for do not resuscitate, meaning that you would prefer at the time that your heart stops that you don't want any interventions and you want to allow for natural death at that time, that would be a do not resuscitate order, would be required to see that through. And you can achieve that on a POLST document. You can specify DNR. But if you don't have a POLST in place, which a lot of times people don't, this form is the form that you would fill out with your physician if you were outside of the hospital. So this is the form that you would need to make sure that if somebody called 911, if EMTs came to your house, you have this paper form, the doctor signed it, and your wishes will be followed. I think it's important to just say about this out of hospital form too. A lot of times conversations about these things will happen in a hospital, and people will go through their decision-making processes and they'll say, I want a DNR. And then in the hospital, they'll put an order in the system and they say you're DNR, but then they're discharged. And if that POLST isn't in place, because the POLST transfers from hospital to home, anywhere you go, it follows you. But if that wasn't filled out in the hospital, which sometimes it's not, you don't have the order in place as soon as you leave. So you actually do need an out-of-hospital DNR to have those wishes respected.
Right on. But is it true though, if you have a POLST, you don't need this form?
In my experience, yeah. I mean, my experience of practicing in hospice in New York State, and I don't know, I think that it's a form that follows people around. Yeah. So that's been my experience. Yes. That if you don't need it if you have the POLST in place, because that's not exclusive to the institution that it was filled out.
I'm going to jump in quickly. Yes, just to confirm that. So the POLST does cover what's in the DNR. The DNR is just related to CPR. So if you do have the POLST, that is covered in that one section of the POLST.
Thank you, Sones. Voice of God. Thank you. Yeah, right on. Good. I mean, and for reference, guys in the audience, I don't know, we've been at this 20 years or something. I've never even seen this DNR form. So I've never signed one. I've only been in the hospital with folks or outside of the hospital dealt with POLSTs. So if that puts it in perspective at all. One thing just to highlight also that you brought up here, Kate, is you use the phrase allow natural death, which is a beautiful phrase to some of us, maybe scary to others, but what's the difference between allow natural death and do not resuscitate? Is there any difference?
That's a good question. I don't think there's much of a difference, because if you're not providing CPR at the time that your heart stops, there's not other interventions, I would say.
Yeah.
People can intervene at that time, like that's kind of, if you're not doing that, then you do allow for natural death. But that doesn't mean that if you're a DNR, you can't elect for some other life-sustaining treatments like feeding tubes or IVs or antibiotics.
Right on. Yeah, look, we'll get to that in a second. We'll get into the guts of these forms, whichever form we're leaning on, POLST, Advanced Directive, DNR Form. Let's cut to that in a second. But I think what some of you folks out there might hear this language AND or allow natural death. My understanding here too is that that's synonymous with DNR. It's sort of updated language, and it's coming from the death positivity movement of trying to see dying as a positive, at least an active process, not just a time where we don't do things. It's a time where we do things, it's just, I think, languaging it in a positive light is the gist. There's so much fear around death. And a lot of us with trepidation around our own death, especially in the healthcare system, you might worry that the healthcare system is going to ignore you, or dying means that they're not going to care as much. They're going to not do things. So framing it around a positive just allows it to be a little less scary for some of us. But I think technically you'll most often hear language DNR is still sort of the term of art in the field, but increasingly you might bump into this AND version, allow natural death. And you as a person, you choose whichever of those phrases means more to you.
Yeah.
Okay. Sorry. Is there more you want to say?
One thing to that, just that is a big fear. So I'm just mirroring that sentiment that a lot of people worry that they'll get a little lost in the medical system. And just from experience as a provider on kind of both sides, like acute care and in hospice, it's just DNR people think is, DNR is not do not treat. Hospice is not do not treat, right? You can still receive care for comfort, symptoms, anything else you have kind of going on or that comes up. It's just that it's confined to more what your goals for your own care are. So yeah, neither of those things are do not treat. And that's a good myth to dispel.
It's an important myth to dispel. And I still hear horror stories where it sort of ends up feeling that way, that there's the DNR guys are over there and everyone else is over here. That's not the way it's supposed to be. Sometimes, as in healthcare and all things healthcare, sometimes that happens, but that's not the way it's supposed to be. And that's a note to all of us to advocate for ourselves and each other. DNR does not mean do not care, do not treat, etc. Okay. All right. So finally, okay, so what the heck is in these forms that we're talking about? So CPR. So this is the code status phrase you'll often hear, right? What is your code status? And then TBs, you hear code blue and all this. So code status, maybe we'll start there, Kate. Tell us about CPR, code status. What should we be thinking there?
Yeah, code status is just what you want your medical team to do or how you want medical providers to intervene at the time that your heart stops. CPR is cardiopulmonary resuscitation. So it's not only chest compressions and potential shocking to get your heart beating again, but it's also providing, artificial respiration for as long as needed during that time. Yeah, I think
Yeah, we could just run the list. I mean,
Yeah. Um, you mean go through the next one?
yeah, yeah, yeah. We'll just run this list. So CPR, that's specific to chest compressions, um, or electric shocks. That's when your heart has stopped. Do you want them to try to bring you back? Do you want them to restart your heart? That's kind of in the CPR defibrillation bucket. Then, as you said, that often goes together with intubation, the pulmonary, cardiopulmonary resuscitation. And so the pulmonary part is often intubation or some sort of support for, breathing for you. And you on a code, you might be able to, on some level, tease out the cardio from the pulmonary. I want chest compressions, but I don't want intubation. But generally, that's not a good idea. These kind of come as a bundle. It's sort of like the question is, do you want the doctors to try to bring you back from death or to help you go peacefully? That's really in so many ways, the choices. If you try to approach these forms as a menu and take a little bit of that, but not so much of that, it quickly just falls apart and becomes a non-functional, impractical document. So we tease these things apart, but in so many ways, they go together. That's not totally true. So on some level, like artificial nutrition and feeding tubes, that's a big one for me, Kate, and at least in my conversations with people, that one can get really thorny, or difficult because food is such an emotional subject. Is that true in your experience too?
Absolutely. I think this is one of the things that people struggle with the most in making these decisions. Yeah, food is and feeding is how we help heal people. It's how we connect with people. It's how we celebrate things. It's social. It's really hard to make decisions around feeding. Specifically, if somebody just doesn't want to eat, which is a really natural part of the way that end of life kind of chapter can look towards the end. And artificial nutrition is making the decision to receive nutrition either through a tube that would go through your nose and down into your stomach, and that's temporary, or for like having a surgical procedure to place a tube into your stomach and receive artificial nutrition because you're not eating any longer.
Yeah. That one, is just saying, Kate, is so loaded. And this is primal stuff. And this happens so often with families. And, as you said, as we're dying, as the body's shutting down over the course of weeks and months, our interest in food will almost always wane. And very often that's the body being smart. We can actually, one thing I think that people don't appreciate is that forcing food or fluids into a person can also cause harm. I think a lot of us say, oh, well, of course, we don't want our loved one to starve to death, or I don't want to starve to death. And we see the person not eating, and it can be so, at a primal brainstem level, so difficult to behold. It feels like if only this person would get some food into them, then they live on. Food equals nutrition equals life. But I guess our point here is there's a point in our life's course where food actually can cause harm. So it's not like, well, why not try it? At some point, why not try it is because you can cause a lot of suffering. Body can't process the food, whether it's coming in through a tube or through our mouth or through a vein. It backs up, causes pressure, causes discomfort, nausea, and our body can't metabolize the nutrients anyway. So this is not a small, this bullet is in some ways the most complicated emotionally and psychologically. And it really requires some conversation to know when is food actually hurting versus helping.
Yeah.
So,
Yeah.
yeah. What else do we want to say on this in terms of the content of the form here, Kate? Anything else of note?
We talked a little bit about mechanical ventilation. The last two, antibiotics and IV fluids, I think are interesting pieces of the puzzle too. I think IV fluids is similar to that tube feeding conversation, where a lot of times caregivers will take on a lot of personal responsibility. Like, I'm allowing my loved one to starve. I'm allowing them to dehydrate. And truly, if they're not eating or drinking themselves, this is their body's way of telling them and us that they don't need these things any longer. But of course, it's always an option. So that's why it's on the form. And I've seen IV fluids, they can prolong life, but then it's kind of that question of, what quality of life are we prolonging, right? So this is why having these conversations preemptively about your values and when you would and wouldn't want your life prolonged is so important. And antibiotics is like one of those things that I think we think of as fairly benign, and why wouldn't you want antibiotics? But actually, it can also serve to prolong life. And again, we have to kind of look at that conversation, which I think we'll get into when we're talking about values. At what point wouldn't you want life prolonged anymore? Because there can be agency in there, right? We don't have to just keep going to have an outcome that's, not really how you envisioned that last part of your life.
Yeah, and I'm with you. I mean, antibiotics is, and again, it kind of can fall on, as a layperson, I can imagine, well, why not try? What's the harm? Well, that may be the case. So much of this is case by case. It certainly, we'll get to as you say, the values, but even in any one of us, our values are likely to shift over time, or our tolerances are likely to shift. So people's code status and how they fill out an advanced directive or a POLST or any of this stuff is liable to evolve and shift over as you age, as you move through illness. So one thing to get out right out of the bat is you can change your mind on all these things, one point, and fill out a new form, change your code status, change your status, etc. But back to this point that you were pointing to, why not? Well, antibiotics, similar to artificial nutrition or IV fluids, at some point you can cause harm in some ways. There are side effects to antibiotics very often. But the bigger case here, I'd say, is, when death is coming no matter what, remember, we all die. We're programmed to die. So the more we interfere with that natural process, propping ourselves up with supporting breathing or the heart or kidneys or any of the ways that medicine intervenes in nature, into nature's course, what you end up doing is you might end up accidentally selecting out for increasingly difficult deaths. If a body's really trying to die, pneumonia used to be considered the old person's friend. It's oftentimes a thing that took them finally in the middle of the night or relatively peacefully. And pneumonia wasn't the problem. It was just a symptom of the body not being able to fend for itself in this world. And so if we keep interrupting these relatively comfortable ways of passing, we accidentally select out for more and more difficult ways. So again, that's a tricky thing to get across, and it's so case by case, but just for thoroughness on this, I wanted to pick up on your point there.
Yeah. Go ahead.
Anything else on this one, or shall we keep on moving, Kate?
Yeah, I think that the only other thing I was thinking is just I've read in the past, I don't know if you can kind of attest to this or you've read this also, but just in thinking about these things, I think it can be a struggle to make some of these kind of final feeling decisions. But I think you were talking a little earlier just about like the natural process at the time of death. And I think there's even kind of research to say that when we do allow the body to do its natural thing, it kind of takes care of us, like with the feeding, like that there's, as we kind of go into a mode where we're not eating anymore, that the body actually releases chemicals, like, it could be incorrect, but oxytocin or those things, those chemicals that like make our bodies actually feel better. I'm not sure if you've heard all that or can kind of confirm or deny, but I do think that our bodies know what they're doing at the end of life. And I think that there's a time and place for treatments, and there's also time and place for trusting that, our bodies kind of know how to carry us through these things. And even in a way that when we don't intervene, it might actually be more comfortable than if we do.
Right on. And then what you've just said points to really the craft in all this is exercising good judgment, because all these things are in motion and moving targets. It's really, we're trying to strike a real-time communication balance and good judgment of when to pull which intervention, when to leave well enough alone. That's not on any one of us to do together, but this is on us as groups, as families, with our medical teams. So one of the meta messages in all this, guys, these forms are communication tools. So what we're really pointing to is communicate with yourself, with your family, think about your own wishes, be in real time up to date with your physician so they know what you're thinking, et cetera. It's a dynamic that we're pointing to. And back to your point too about the body's wisdom. One thing like in our lifetimes, I think we've lived where in the sort of the nadir where humans really thought that they could, outdo nature on all fronts, whether it was, fake breast milk or, formula versus regular. I mean, all sorts of ways. I think we're realizing the body actually really knows what it's doing. So to your point earlier, oxytocin perhaps, but ketones, yes. When we're in a catabolic state, we release hormones that can be peacemaking and comfort making. One of the things when death is coming, I often, I keep an eye out for renal failure as one of the final things to go. And I get a little bit happy when that's the mode of death for folks, because in general, when the kidneys aren't working, certain toxins build up and can put us in a kind of a pleasant, dreamy fog. So there's all sorts of ways the body, we've been dying for a long, long time. And the body has this in a lot of ways. And that's not to say it's a cakewalk and easy, but compared to what happens when we start intervening, sometimes nature has it just right. Very often she does. So anyway, shall we move on?
Yes, yeah.
Okay. Okay. So we kind of delivered a little bit of this, but maybe just for a moment here, is there a synopsis for the guys out there? When to think of which form? Anything to review here?
Yeah. I think, I actually have seen a lot of the out of hospital DNRs. I've used a lot of those in my experience. It might just be a little state to state difference in practice, and either is fine. But in that case, it's usually when somebody's on a hospice program, and hospice programs are always asking what goals of care are, right? So in that case, you may not need the POLST if you have your DNR and you're talking to your hospice team and you've decided that you want a comfort approach. And by the way, you can be full code on hospice. You can get IVs on hospice. I'm not saying that means that you can't have any of those things. It's just that those conversations are very natural in that type of care, and that you might not need the full pulse. But I would say that it's an important form to have if you have specific things, the medical treatments that you don't want, because none of us ever know when we're going to be in a situation where we can't voice what we want at that time. And that's why, revisiting our wishes frequently and when there's life changes or there's changes in condition is really important. But yeah, pulse would be important if I say I absolutely don't want a tube feed, or you can try antibiotics, but only one round, or you know what I mean? Like kind of saying those specific things and having those in place is important. And especially if you're not on a hospice program, right? Which you don't have to be thinking about these things. A pulse would be really important to make sure that between all of your medical teams, it's really well understood what treatments you want and it's in writing.
Right on. Yeah, and that sounds just right. I would just highlight something you just said there, which is, revisit these forms as your condition changes, as technology and medicine changes. You may lose or find faith. You may, all sorts of things happen to us over the course of a lifetime that changes how we feel about being in the world and what's possible and what we're willing to live with and couldn't live without, etc. So keep a sort of, again, these are dynamics. These are communication tools. Revisit these forms if your situation has changed, either your medical situation or your living situation. You might get in the habit of reviewing them annually, just making sure they're up to date and going over them with your family, friends. But one thing we didn't really mention on the pulse, there's also a lot of these forms will have some ways to name your proxy, which in so many ways, Kate, I bet you and I would agree, is probably one of, if maybe the most important piece of that puzzle, because so many decisions, there are details and things are happening in real time. Stating specifically your wishes can be very important, but given all that dynamism, it can be most important to have a deputy, a person who in real time can make decisions with the medical team on your behalf. That's really, really key. And that's often in these forms to designate. So anything else you want to say about proxies here, Kate, or anything else?
I don't think so. Just the importance of having one. Can't understate the importance of having one. But and choosing wisely in that person and talking about all this stuff. So it's not just a form that they're looking at, that they've had real-time conversations with you about these designations and things that you've chosen. Because even when it's in writing, I think it can be hard for a person to make decisions that might have been against what they would have wanted, or they really want to try this one thing. But if you've had those conversations, it just takes the onus off of them and they know how to act in accordance with your wishes. Because at the end of the day, if you can't speak for yourself, your proxy actually can make different decisions for you. So I guess that's a whole, maybe another webinar that you've probably done, but yeah, just the importance of that person and the importance of those dialogues with them.
Right on. And maybe we'll see what comes up in Q&A. Maybe we'll circle back to that proxy note. But okay, moving on for now. Okay. By the way, Sonia, I love your slides as always. So good.
It'll
Okay.
make me laugh too. I was like,
So good. So, okay, so where to keep these, these forms, they're an important piece of paper, especially that POLST, the medical order. So they need to be accessible. And oftentimes these moments where these things are summoned are in a crisis. An accident has happened, passed out, or heart stopper on the kitchen floor. This is very often in an emergency moment is when these forms are going to be needed. So it really matters that they are accessible. So any tips for us here? Let's think here, Kate. Yeah.
Oh, sorry, I didn't mean to interrupt.
Please.
I usually advise people to keep these in a visible spot, like the refrigerator, the tape to the back of a door. Like if it's something that says do not resuscitate, right? That's an important order that you would want people to follow. So keeping it on a refrigerator, taped to the back of a door, or if there's someone who's not getting out of bed, by the bed, are all really safe places to keep this form. However, some people don't want to look at this form all the time, and that's fair. That's fine. Just make sure whoever's with you in your house knows where to find it and quickly, so that there's like a common place and everybody knows exactly where to go to get that form if 911 is called.
Right on. And it can be helpful. It's not the same thing as having a form, but taking a picture of it on your phone, or there are also these vault spaces that are established, like Vinca or mydirectives.com. There are these third-party places that have gone through all sorts of work to have a vault, a safe place where you can upload these documents so that they'd be accessible. Let's say you're on the road and something happens, you end up in an ER away from your local hospital, away from your forms and all that stuff. Well, that's a time where being able to reach into the cloud to access your form can be so helpful. But just wherever it is, just keep that in mind, especially if you're feeling towards the end of life or have been very, very sick, and it's more likely than not you're going to need this form in a moment. Just be cognizant of it. And that good advice, Kate, of having it like on the fridge and things like that at home. A paramedic, there's a lot of stories of people have had done a lot of work to get their advance directive just right and communicate their wishes to loved ones, etc. And then 911 gets called, and the poor paramedics in the heat of things can't take a wailing spouse word for it without paperwork, and they will start resuscitating the person. And it can be really, really difficult for everyone, including that paramedic. But they're following their ethos and law, and they have to keep going until they have a reason that they have to stop. In other words, a POLST. So it's not a small point. All right. Anything else, Kate, on this one?
I don't think so, no.
All right. Yeah, I'll try to stop talking so much so we get to Q&A, but there are other things besides just the code status and other things we've talked about. Anything else we want to bring into the mix here?
Yeah, I think just a little conversation or note to say that the forms don't have to be so black and white, like, yes, I want a tube feeding. No, I don't. Yes, I want a ventilator. No, I don't. I mean, they are, but there is option to say something like a trial of intubation, or you can do a tube feed for a couple of weeks, or, you know, there is the option there to trial things. And I bring that up to say that there is a little flexibility. If you feel like maybe you were in a position to maybe want to try to see if that could be a bridge to a new place or back to wellness. But there is just something to consider there, in that when these treatments are started, they're all like life-saving, life-sustaining treatments to various degrees. And so if they're treatments that you lack capacity to really like direct, it's going to be on your decision maker to direct that from there. And if you do like a trial of intubation, something I kind of talk with people a lot about is you can do those things. That is an option, but you do want to think about the fact that if you've stated, I only want this for 2 weeks, things aren't looking better, that does put a big decision on a decision maker, even though it was your decision, right? Because we're then removing them. And I think emotionally that can feel like a lot for people. So it's really just something to consider and something to think about if you do kind of do trials of things.
Yeah, thank you, Kate. It's a really key point. And to be clear, withdrawing life support versus never starting it, from a bioethics and legal point of view, that's settled. And there is no difference from a bioethical or legal framework between never starting, say, mechanical ventilation and starting it, but then stopping it. But to your point, Kate, while there's no ethical distinction, it can feel very, very different, certainly for the patient, but also for the family member. Having never been clear that the person did not want mechanical ventilation, didn't want that kind of life support, and not starting it can feel very, and letting nature take its course can feel importantly different than asking family of the veritable, the when to pull the plug moment. Again, either way, ethics would say it's the same thing, but the experience of it can be markedly different. So it's just like you say, Kate, something to keep in mind as you're trying these various routes on for size. And especially if you want to wade into the gray zones, trials of things. Artificial nutrition is a great one, until there's proof that the food or fluid is actually doing harm. In certain situations, you can imagine wanting to give it a week or so and watch the body closely, how it's processing the intake, etc. But anyway, you've said it perfectly. I'll shut up and move us to the next slide. I think we just got one more and then we get to the fun stuff.
Yeah.
Oh, yeah.
Yeah. This is just, for me, this is kind of like the core of this whole conversation, because I think that there are a million hypotheticals. We're never going to be able to figure out what exactly is going to happen and how we're going to decide in those moments. And sometimes, I'm going to back that up a little, but I think just talking about the values is something that we can do, like nailing down what our personal values are is the most important thing we can do for our healthcare agents and for these future decisions, because they help knowing what your values are. And when I say that, I mean like what brings your life meaning and joy, and in what scenarios would, I'm taking this from Elua Arthur. I love this statement though. It's so good. In what scenarios would living be worse than dying, and what kind of conditions of living would be worse than dying for you? So thinking about those things helps us be able to approach, instead of saying, I would never want this treatment, or I would want this treatment, or it's kind of hard to tell when it's not imminent. But having a values-based approach helps you know when to draw this line, knows when to draw this line. It helps your agent, your healthcare agent that you've appointed, have conversations with the physician, perhaps saying like, this is really important to this person. If we do this treatment, what are the chances that this person's going to be able to experience life in this way? So it's kind of just like a way to like reel it in and not try to go down a million different rabbit holes of what could happen, but just knowing that we're equipped to maybe know how to make those decisions when they come.
Right on. Yeah, I'm right with you every step there. And shout out to our friend Elua in LA. Um, so I think, one just sort of again to kind of circle back to the context. Remember, medicine, the healthcare system is a big, powerful thing, and our technologies are impressive. We can do many things, but not everything. And just reminding ourselves here that medicine is going to, you're patient X or patient Y, even if you love your doctor and they know the way medicine is these days, it's very hard to know a patient very well for very long and for a patient to know their doctor very well for very long. There's so much happening. So, all the defaults are going to be more care, more care. All the presumptions are going to be that you would want to keep going if you have a pulse, period. That life equals having a pulse. These are these very reduced, very physiologically driven bottom lines that the healthcare system, that medicine presumes. But as you're saying, Kate, we're not just a pulse. We all have different ways of being in this world. Things are differently important to us, differently unimportant to us, one person to the next, and within ourselves over time. So the thing to track underneath all these sort of logistical decisions and this paperwork is, who are you? Who do you want to become? How do you want to go out? These are the questions, the big ones underneath all these clerical bits. And if you're clear there, then a lot of the rest can often kind of flow a little bit more easily. And then the last thing to remind each other of that, consider these forms, again, by themselves, they can be a little dry, but using them as conversation starters, as ways in to get to what's important, to think through things together, to imagine these futures. Think of them as conversation starters. Okay. Well, Kate, thank you. Shall we head over to the audience Q&A time?
That sounds good. Thank you.
All right.
We've got some good questions that came in while you guys were covering all that. So I'll just jump in here. What's the advantage of having an advance directive if the hospital is most likely not going to honor it in the end? And I mean, most likely versus sometimes, but you guys can get into that. So why should people have advance directives, even if they might not be honored?
Okay, you want me to start? You want to jump in?
Yeah, you can start.
Okay. All right. Well, I'll just say, well, we just kind of covered it. I think why have an advanced directive is treating it as a conversation starter, treating it as a catchment for important thoughts and decisions, important realizations about yourself, important things to communicate with your loved ones and to hear from your loved ones, their own feelings. A lot of people, we've talked to so many people who their advanced directive really reflects what's most important to their spouse, because that's what's the most important to them. So yes, advanced directives, I hear the reality in your comment, maybe very cynical, and I share it, but I will say most of the time these days, advanced directives do find their way to being honored. It's still an issue, and this is why the POLST has come along, but I wouldn't give up on advanced directives for many reasons.
Yeah, and just because they don't hold that weight of a medical order doesn't mean, just mirroring what BJ is saying, but doesn't mean that it's not incredibly valued to have your voice in the conversation, even if you can't be speaking at that time. It's important to, the physicians caring for you. It's important to the people making decisions for you. And hopefully those things do get followed. That's really the goal with that.
Yeah. And maybe we haven't said it out loud as you're saying that, Kay, just remembering, yes, this is on us to think through what's important to us as people. And yes, talking about it with our loved ones, our family, friends, all the people, our inner circle. But don't forget, if we haven't said it out loud, don't forget to discuss it with your doctor or your doctors or your medical team. A lot of us have multiple doctors. Make sure to share your wishes, not only the form, but have the conversation with them too, so they know and so they can advocate for you.
Yeah.
Okay, so what else?
Thank you. Next question. So DNR allows for natural death, but if suffering or pain is involved, can that be treated?
Yes, absolutely. DNR does not equal do not treat, and certainly not symptom management, whether you're working with palliative care, whether you're working with a medical team and receiving treatment, whether you're on hospice, symptoms can always be treated. There's no hindrance to, there's no medical decision that you can make that I'm aware of that excludes you from having your symptoms managed.
I would add, ideally or theoretically or ostensibly, a DNR order, what that should free up is so your medical team isn't watching the monitor and watching your EKG strip results. If they're not worried about those things as much, then ostensibly they can be more focused on your comfort, on what brings you meaning or peace. That's the way it's supposed to work. Is that's supposed to free up time to devote it towards your comfort. But bottom line, to your point, Kate, symptom management could always be a priority, whatever your code status. That doesn't mean that you don't have to advocate for that symptom management. Symptoms often do get short shrift in the medical world, especially when life or death is on the line. It's sort of felt that comfort is less important. That is not true, right? I mean, comfort is always important, perhaps especially so in those final moments. So it may be a note to advocate for yourself, but symptom management should be possible all the time.
Great. Okay, next one. What directive would you suggest, if any, for a situation of terminal agitation?
That's a good question. Normally we're seeing terminal agitation when death is more close. And very often someone is on a hospice program. And I think that there are things in place. It's not necessarily a directive, but there's orders in place to be able to assist with those kind of things. I also just want to quickly state that there are your state-by-state legal forms, but there's nothing stopping anybody or just putting this in a living will of saying, if I'm having agitation, these are the things that actually help relax me, or these are the things that could support me. People really think about it in kind of technical ways, but if you think about yourself and what brings you comfort, I think that's a really valid part of a living will, or even an addendum that you just kind of type up yourself of things that might be important to you near the end.
Yeah, and I take your question to mean, I'll take it too, also to, and maybe I'm misreading, there's a little bit of code around delirium in general. I might have watched as a physician, my own feelings about what delirium signifies, terminal delirium. That is, terminal delirium is sort of disorientation, delirium, that is common in the final hours and days of life. As the body is just coming apart, as it's shutting down system by system, that includes the nervous system and our ability to think clearly and orient to time and space. And it's very common that no matter what you do, that there's some delirium in the final throes. I used to think, my medical opinion was, that is a kind of suffering, that confusion, and we should medicate it. So there are medicines, lots of them, antipsychotics, Haldol, Seroquel, Zyprexa, all sorts of them, that can effectively tamp down the delirium and quiet the mind. Essentially, very often that means kind of just being asleep. But some people have strong beliefs that what may look like chaotic or disoriented behavior to us on the outside is something essential or important for the person who's actually doing the dying. And this may be the case. I mean, what do we know? It's so tricky. It's so hard. We haven't died. None of us has died yet, at least in the ways we know how, we understand. So it's hard to say how it feels to be in a delirious body in the final hours of life, and whether whatever's coming up and out of the person is essential and not to be shut down, or is just a chaotic suffering. So it kind of gets at your belief system here too. Again, my priority in the past has been to treat that delirium. I am much more open nowadays to just letting it be if that's what people want. But it's an open question.
All right, next one is, I'd like to know what BJ and Kate feel are the best choices to make on the POLST form. And this is within the context for you personally, just kind of wondering what you, BJ, and you, Kate, would pick for yourself, because obviously we can't pick a POLST choices for someone else, but they'd love to know what you would choose for yourself.
Mhm.
That's a good question. It's going to change. It's going to change with time. Right now, my designations would be to be a full code, to be intubated if I needed to be intubated. I think depending on the scenario, I mean, I'd be open to IV fluids. I'm open to antibiotics. Tube feeds, as we talked about, is a really nuanced conversation, but I still think that the physical body that I'm in right now can tolerate a lot of those side effects. And I know that. So I would be okay with treatments because today I'm in a place that I think I could reasonably get to a new place. If we're just talking about like I had a car accident or something, because there's so many avenues you could go with this, right? But I think that will change in time, as my body changes, as different illnesses set in. And for me personally, I would be a proponent of allowing natural death when the time comes. And again, I think I'm trying to keep it in a nutshell, so I'm not trying to be evasive. But I do believe that when that time is closer, that I wouldn't want a lot of extra medical interventions. I would want to I would want to live out my time without the added risks of side effects or prolonging life that might not align with how I want to live.
Yeah, thanks for jumping in there, Kate. It's a great question, and it's a difficult one. I would just say for now, and I've moved around on this myself. I'm in a full code mood. I'm these days. I think I would check all the full code boxes, full court press right now in the body that I'm living in the time of my life. And the context for me would be, and I am would be so full code for now with a lot of conversation with my proxy around, is this like an accident, an acute event, just something just happened and we got to get over a hump? Or does this reflect some smoldering, more serious illness underneath it? That could make a big difference in my decision making. So I would have a lot of conversation on the nuances with my proxy, but I'd probably check the full court press for now. And I'll just say one more thing. I want to keep an eye on, as I get older, I become increasingly enamored with nature and the natural course of just about anything and everything. And I also have come to see human nature as part of nature. So I also have a great fondness for what medicine can do. And in a sense, it's a kind of nature. But like we were saying earlier, the wisdom here is to know is to have the good judgment of when to pull which tool for which thingy, which situation. So I'd say the context is I'm increasingly deferential to nature, but still would be at this point full code, and do everything at least on a time trial basis. Give it a try.
Great. Kate, I want to check in with time for you. We've got a few more questions. Are you able to go a little bit past 11? Okay, great. 1 second. We've got Karen with her hand up. Karen, you may have to unmute yourself on your end.
Thank you, Sonia. I'm unmuted. Hi, BJ. Hi, Kate. Kate, I do remember you. Such an important topic, and I think of the POLST as the document that should be pinned to my hospital gown. But I want to loop back something you said, BJ, about when you were speaking about do we want interventions, or do you want your doctor to help you go peacefully? And that was something I focused on, because at end of life, I think the conversation around the documents that we hope will help us die well or have a soft landing, we say we don't want to hasten death nor prolong life. But when I think about my relationship with my doctor, whom I'm so fortunate to have a close, strong relationship about 2.5 years in, if I stipulate no hydration, no artificial nutrition, I think that's a pretty clear message about where I would like to head. And I just wonder if more can be said about what does it look like when you have a conversation with your doctor? How can you help me go peacefully? Which I think is probably a pretty tough question for them to answer. And I just am so interested to hear what you both might say about that, without necessarily hastening death. But what can we ask our doctors to do affirmatively to help us die without medical aid in dying, which we do have in Vermont? Thank you.
Karen, as ever, I love your questions and the comments underneath them. Thank you, as always. Yeah, I have some thoughts here. I bet you do, Kate, too. I mean, maybe I'm already talking. I'll keep talking for a sec. One thing, and this is the problem. So every time we choose a word, it's so problematic because, like, as you just said, Karen, one way of understanding these things is, do we want our doctors in general, do we want our doctors to intervene and do everything to kind of keep this heart going and keep this body going? Or would we rather them shift their focus to our own comfort and actually have them actively help us be comfortable and find peace? And even as I say that, I've set up a false dichotomy. So you should be able to have, it's not impossible to have both too. It's not like go with medicine and be uncomfortable or screw medicine and be comfortable. It's complicated. So one thing just to say and comment there is that's something of a false dichotomy, but it still can help organize your thinking and the doctor's behavior. So that's one point. The second point would be how you can help your doctor here is, and they're not likely to be any more facile with this conversation than you are, and maybe in some ways even less so. They don't know, they don't want to say the wrong thing. The classic thing is doctors don't want to take away hope, so we all collude, we don't talk about these things, etc. So you can help yourself, Karen, and your doctor by saying, hey doc, can we talk about, it might be difficult, I don't know what's possible here, but can we talk about when I die, what are my options and how to play that out? So that can get you into the conversation. And another one, like you're saying, Karen, shy of actively hastening death with our, medical aid in dying laws, 10 or 11 states have those laws. Well, so shy of that, that's an intervention, really. Shy of that, what you can say, it's a very big difference. You can say, hey, doc, I don't want you to kill me, but please, but I really would like to start getting out of the way of death. That's language I've used a lot. It has seemed to unlock some thinking and feeling for people, myself included. So I don't know if that speaks your mind, Karen, but at some point that's a way to begin to say, okay, we're not going to go back to the ICU. We're not going to do this. But instead, doc, I'd really love it if we, how are you at symptom management? Or do you know a palliative care team? Or what's the hospice like around here? Because, boy, I sure want to be comfortable when it's my time. And I'd love that to be our priority. And you can you can feed him this information or her this information and further the conversation. Those are some thoughts. What do you think, Kate?
Yeah, I love that you asked this question, Karen, because I also love that you have such a good relationship with your physician, because I think it makes it easier. Yeah, I think it makes it easier to have these conversations. Not everybody feels that way, but I think just the fact that you bringing it up is part of the answer to the question, right? You bringing up your values in comfort, in end of life to your physician, because they're not always going to bring it up to you, or they might not bring it up as soon as you might like to start talking about those things. So I think, first of all, just bringing the conversation up, and then those kind of values-based conversations that you have with your agent are really great conversations to have with your doctor, and just say, listen, however things go, this is what's important to me. Living a life that looks like this, being able to experience this is important to me. If I can't achieve those things, I would like to take a comfort-based approach. And yeah, like BJ said, do you have, what's your experience with symptom management? What's your experience with palliative care? Do you have any referrals? I think there's no wrong time to have palliative care on board if you're thinking about these things, because those are the experts in having these conversations and helping to facilitate that too. So not sure if I had that much to add, but I think initiating the conversation helps them understand your goals and talking about your goals too.
Well, beautiful responses and helpful. Thank you both so much. Thank you.
Thank you, Karen.
Karen. Okay, I've got a few more questions here. Because many people do not have a strong relationship with their doctor, or maybe even a primary care doctor who knows them, what specialty is most likely to be open to completing a POLST for a healthy but frail elderly patient?
I would think whoever the person's general practitioner is, whoever they see the most, or if it's a gerontologist or whoever they're seeing, any physician can fill out this form and have these conversations. So whatever is the easiest point of access would be my answer. What about you, BJ?
I'd say yes. Someone who knows you, I hear you. They may not know you super well, but whoever you know best or knows you best, and with whomever you're working most closely, can be a primary care doc. But beyond that sort of whoever knows you best statement, I would say if you had to pick if the question really gets at like what discipline to reach out to, well, geriatrics, which is essentially generally primary care for older persons, or palliative care. Those I think would be the two specialists that are most likely to be facile with these forms and be ready to engage you in a conversation about this stuff.
Yeah, and if you don't have those people, you can ask for referrals. I think palliative care is a great route because that's part of palliative care, is being really well versed in talking about those things. So if you don't feel like maybe your easiest point of contact, you can have those conversations, or you're not feeling really sure, or you're not feeling good about the exchange, you could ask for those types of referrals. Yeah, good point.
Yeah, right on. And then one more thing, as you're saying that, Kate, I realized that for like signing a POLST, it is a medical order. So it does need to be signed by a doctor. But a lot of clinics work in teams. So oncology, for example, is common, but any specialty clinic these days, especially in comprehensive health systems, will have a team. So you may be very close with the nurse on your team. So that may be the really good person to have these conversations with. Then he or she, then the question is who's going to sign the form? And so that may be take a minute for that nurse to find who's the right doctor to weigh in and sign based on the conversation you have. So I guess I'm saying two things. It needs to be a doctor on some level, but as a way into the conversation and to further the conversation, that may often be with the chaplain, social worker, nurse, someone else on the team who knows you best, who has time to talk these things through. So in case that helps.
And just a quick shout out that physician's assistants and nurse practitioners can also sign POLST.
Sorry, yes, very important point. Thank you.
Okay, we've got just two more here. So this person said, given the good point about advanced directives changing as we age, how often do you recommend revisiting and revising our advanced directive?
I think the rule of thumb is that to revisit them when you're relatively healthy, revisit them at like major life changes, like a move or things like that, or like I don't know, every 5 years or so, I think would be kind of like a rough estimate to just revisit like where you're at in life, how are things looking, but I think they can be revisited more frequently when you're experiencing illness to see, because they don't have to be concrete, right? And as things change and with treatment, without treatment, how things are looking, you can make different decisions. So just a little bit more frequently, I think, when you're experiencing illness.
Yeah, I agree. Anytime your condition's changing, improving, better or worse, new treatments, opening up new possibilities, or you're running out of possibilities from a medical point of view. If we're dealing with cancer and it moves from stage 3 to 4, there's some change in your medical status. But otherwise, I think throwing a little ritual around this process to kind of take some of the angsty bits out of it and just get in the habit of it once a year. Oh, it's our time of year, between Thanksgiving and Christmas and the family together, we're going to revisit our advanced directive and our POLST. It's a nice habit to get into. And again, a little ritual takes some of the angsty thought out of it.
And stuffing always makes things better anyway. Okay, let's see. We've got Deb, you've had your hand up 1 second.
Hey,
Yeah. Hi, Deb.
yeah, I just have a question about whether or not you can give some tips about how to talk to family and friends that are maybe not, they don't have a cancer diagnosis, but they're aging and you see their health getting more complicated. Like from my experience, most everybody is pretty fine with talking about do not resuscitate orders, but when you start talking about POLST or even I have so many people in my life now as they're aging that probably should be looking for palliative care, and the words palliative care and hospice and all of those things are just so difficult, and POLST, because it's so specific, it is really scary. So I just wondered if you had any tips for how we can help empower people that aren't watching Mettle and aren't reading your book and aren't really making those kinds of steps, but they're just sliding into, or you see friends and family sliding kind of into oblivion without even thinking about these things. So thank you.
Yeah, oh Deb, thanks for chiming in. As always, you too. I appreciate your thoughtful questions, and it's a real challenge. This is a good one. There is not an easy answer here. And as you and I have talked, Deb, sometimes our work as loved ones or as friends, oftentimes is bearing witness and abiding people who are making decisions differently than you might. So not to cut to that answer, but sometimes the answer is all that's left for us to do with loved ones is just not run away and hold the space for things to play out. As you and I, we both know that's an invaluable and extremely difficult skill to cultivate. Now, upstream or beyond that piece of counsel, if you can't get if they're just not going to take up these forums, if they're just not going to take up this conversation in a more formal way, in some ways, advanced directive conversations are often happening. And when people make statements like, oh God, when it's my time, I sure as hell don't want to be anywhere near a hospital. That's a kind of an advanced directive. And people paying attention can extrapolate and say, okay, well, therefore, we're not calling 911. Therefore, it's probably really important to have a POLST form. You can extrapolate from these sort of value-based general statements. It's imperfect, but it can give a little bit of guidance about who this person is and therefore what they might want. Again, they may never get to the forms. They may never have the formal conversation, but tracking comments like that can be really important. Or the other side, I'm a fighter. I want to go down swinging. You can kind of presume when people talk like that they're going to want every intervention to try every intervention. Right. So here's another layer of an imperfect answer to your very important question, Deb. But listening for these kinds of cues can direct a family, a proxy, a doctor if they're paying attention, and they can be something of an advanced directive. Kate, what else? Any other thoughts from you? This is a big one.
Good thoughts that you added already, but to add to that, I think that if somebody has a DNR, so there is just that little bit of like, it's veiled, all of this stuff that we talked about, people don't really know about. And so if you know a little bit about it, like you went to this webinar, you worked on your own, I think those are invitations to share, like kind of leading by example. Like I went to this webinar and I actually learned about, I know that you have a DNR, and I know it really depends on the relationship with the person, but I know you have a DNR. I'm realizing there's a lot of other stuff that they can do that maybe, and I always kind of like, we'll use myself. So I'm like, I wouldn't really want. And so entry points sometimes come from having the knowledge about the thing and just being like, have you ever thought about that? I've been thinking about this. And two, depending on your relationship, entry point questions can just be like, I really care about you and the care that you get. Have you ever thought about end of life options, or have you ever thought about this POLST form, and what are your thoughts on that? So I think a lot of it's just knowing how to access the conversation, like having an entry point in. And then there's a piece that BJ said, if there's resistance to that, sometimes you just can't push it. I've been in this experience personally where I really kind of tried all the angles. And if people don't really want to go there with you, then you kind of support how you can in every stage, right? So that is very real, but I do think that just kind of thinking about what natural way that you can bring it to the conversation and open it up so there's dialogue can be really helpful.
That's so good, Kate. Yeah, I love your note about Deb. It's such a good note. Like, hey, I was just on this webinar, like you're saying, Kate. Or sometimes, hey, I want you to know my wishes in case something happens to me. It's a little bit of theater, a little bit. So here's my advance directive. Can prompt a conversation and model it, just like you're saying, Kate. That's brilliant. That can work beautifully. Yeah, but Deb, let's keep on thinking and talking about this one too. It ain't easy. I will say one more point is, I think a lot of folks, one of the assumptions that takes us down the wrong pathway is a lot of people just presume their doctor will will know what to do.
Yeah.
And so finding your way to get to the conversation about, wow, medicine can do so many things these days. And I don't know, the doctors, they're too busy to really know us anymore. And gosh, I just learned that, God, man, we can actually hurt people with interventions. And finding some way to get out the defaults of the medical system, that they're going to just do everything imaginable to you unless you say otherwise. That understanding that default can really organize some thinking quickly, and understanding that these days medicine, and it's impossible, it's very hard to be known by your doctor without you actively trying to be known. So sometimes those sort of conceptual comments can be ways into the conversation too.
Yeah, thank you. That's really helpful. And I guess I also have to just realize too that when I have these conversations, that if I'm just planting a seed, it's somewhere in there, even if they can't hear it, because these are big discussions. I mean, especially if people are aging and having major health issues as they decline or whatever. These are really big steps. So just realizing that it may take 6-7 times of going back with little teeny tiny steps too, until people can actually even want to know what a POLST is, or what exactly is palliative care, because now they're just sending me to the pain clinic, but that's not really helping. And so I really, really appreciate what you both have said. So thank you so much.
Yeah. Oh, Deb.
Life are lucky to have you, Deb. They are. And so, as people feel like they can open up to that, it's nice that they know that there's a place that they can go and talk about that. That's huge.
Amen. That is huge. And Deb, your point is so brilliant, so well taken. Like, these things, sometimes you may think like you're talking to a wall, but the 7th or 8th time something shifts, and to your point, have faith that these conversations are landing somewhere. And to Kate's point, what you're really showing as this person is that you care over time. And that sets a stage. And that's on that stage, all sorts of things can happen. And then last note, just be careful with your own sense of responsibility when it comes to the decision-making of others. I know it's tough when you love and care so much, and it could be better for them if they made a couple decisions. Sitting with that knowledge and that love at the same time, and just watching them go a different path, can be brutally difficult. So one last note here, Deb, on this one is to watch your own sense of responsibility when it comes to the decisions of others. A note for myself, maybe you too, Kate.
Absolutely.
Yeah. You know me well, BJ. Thank you. Thank you. I really appreciate all of that very much.
All right. Thank you guys so much Kate, appreciate you going over there to get all these questions answered. Thank you everyone for being here and contributing your questions. It's really helpful for everyone who's going to watch this later. And happy long weekend to everybody. Thank you, Kate. Thank you, BJ.
Thank you so much, Kate.
Yeah, thank you for having me. Happy to join.
Thanks, guys.
Bye, everyone.
Bye.